Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. My name is Joe Ceramelli. I oversee Grand Rounds for our department. First, I'll make a couple of comments about this academic year's Grand Round series. We actually have today's presentation and then a presentation next week, and that will conclude this academic year's series. For today, I'd really encourage you to write in any comments or questions in the chat or Q&A at any point during the presentation. You don't have to wait till the end. We have an opportunity today to get questions answered during the presentation. I can stop and ask Jonathan questions, and we can go through things. So please write in questions, comments throughout the presentation. There is a group of us that works on Grand Rounds, including Semhar and Annalie, who's newer to the Grand Rounds team working on technology. We do record and archive all of the presentations on the department website. And for this academic year, have a couple of sources of funding, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. And with that, I'll have a brief introduction here for today's presenter. Today's presenter is Dr. Jonathan Buchholz, who is an assistant professor in our department, in the Department of Psychiatry and Behavioral Sciences. And for the last approximately 5 years, has directed the Addiction Psychiatry Fellowship at UW. Now he works clinically at the VA Puget Sound on a couple of hospital services. One is the inpatient psychiatry service, and the other, which we'll hear some about today, and I learned a little bit about earlier, is the Addiction Consultation Service, which is a service that he also directs. We were talking beforehand about his longstanding commitment to education in addiction psychiatry. And for 10 years, I think his entire time as a faculty member, has directed and taught addiction-related didactics to medical students and psychiatry residents in every year of residency. And for this extensive work in education, has received 2 teaching awards, 1 WWAMI Region Pro Recognition Award, and an Outstanding Junior Faculty Member Award from the department. Dr. Buchholz also serves nationally on a committee for the Office of Mental Health and Suicide Prevention within the VA to develop treatment guidelines and algorithms for acute alcohol withdrawal, which are in use nationally, and has co-authored the most recent a chapter on medication treatment for opioid use disorders that's in the newest edition of the Kaplan and Saduk's Comprehensive Textbook of Psychiatry, which I believe is coming out next month. So really an extensive amount of work in addiction psychiatry, training, education, and very eager to hear today's presentation. So I'll stop there and turn it over.
All right. Can you see my slides there?
Yes.
Awesome. So, Joe, thank you for that very warm welcome. I appreciate that. As Joe said, I am the Fellowship Director for Addiction Psychiatry here at the University of Washington. I am also a lifelong Husky, so undergrad, medical school, residency, fellowship, and now attending. So this place is very special to me. I love the University of Washington. And so it's really important to me, this topic of really addressing substance use in a meaningful way. This is a multimodal approach to improving the care of those who use drugs. And I'm going to talk today in a number of different capacities for this. I encourage people to please feel free to ask questions throughout the talk. And I hope you enjoy it. All right, so we're going to overview some epidemiologic trends in substance use and overdose. We're going to look at some barriers that patients face when seeking help for substance use. I'll describe the landscape of current medical education in terms of SUD, and then review some potential ways that we can intervene on the structure and content of medical education, i.e. what are we doing at the University of Washington? What can we do more globally? And then lastly, I'm going to describe an intervention that we are doing in the psychiatry consultation line in partnership with the Washington Healthcare Authority which is an equality improvement, really exciting project to help those, particularly with opioid use disorder. So this is data from the overdose dashboard at the CDC, and what you'll see here is the line trends overdose deaths ranging 12 months back. So what you'll see is that starting in about January of 2019, there was a giant rise in overdoses in the United States of America. This tracked along with COVID. And what you can see is that it peaked sometime in the middle of last year, approximately 112,000 patients in the 2022 to 2023 timeframe were dying from overdoses. It is leveled off, generally speaking, and what you'll find pretty much everywhere in the country is that fentanyl is driving most of these overdoses. This is more local data. This is the King County overdose dashboard, which is updated every single day. This is as of yesterday, May 30th, 2024. And what you'll see actually in King County, and this tracks along with Washington State fairly well, is that we haven't seen that sort of leveling off of overdoses. In 2023, we had the most overdoses that we have had in history. And you can see the massive increase from 2020 to 2023, largely driven by fentanyl. So what you'll see there is that purple line in the top right is a combination of opioid and stimulant. So a lot of our overdoses really are a combination of folks who are using particularly methamphetamine and fentanyl. On that lower right-hand graph, you'll see fentanyl really driving a lot of these overdoses, methamphetamine being second, and actually fairly interesting, heroin dipping down from 2020 to 2023. We're really seeing much more fentanyl in terms of overdoses. So these are significant problems, and this is just overdose. This isn't alcohol-related problems. This isn't tobacco. This isn't cannabis. And all of those things are also increased. So throughout COVID, we have seen increases in substance use across the board. So how are we doing in terms of treatment? Let's look at the mental health data compared to substance use data. This comes from 2019, so it is a little bit old, but this is the latest data that is actually documented. Major depressive episodes, almost 20 million people in the United States. 12.8 million of those actually get treatment in some way, medication, psychotherapy, et cetera. That's about 66%. When you add a co-occurring disorder in substance use, apologize for that, 9.5 million adults 18 or older meet criteria for this. And 4.6 of those actually get treatment. So most of the treatment is actually directed at mental health only. So that's 38%. Treatment for both substance use and mental health is actually pretty low, 7.8%, unfortunately. If you look at substance use in particular, alcohol use disorder, 14.5 million people, only 1.1 million of those receive treatment for alcohol use disorder. And of those, even less receive medications. Even though we have very good evidence-based treatments for alcohol use disorder, only about 1.5, 1.6% of patients with substance use in alcohol get a medication for this. OUD is similarly problematic. 1.6 million people suffer from substance use in this realm, and only about 290,000 got treatment for OUD in 2019. Representing about 18%. Now that number has increased slightly, and I'll talk about that in a second, but it is still under where we want it to be. So substance use disorders are in the DSM. These are diagnoses that psychiatrists should be facile with. This is in our realm of treatment. And what you'll see is of the patients who have substance use disorders, so the 20 or so million people, about 38% actually have co-occurring mental illness. When you look at it the opposite way, of the 42 million people with mental illness, almost 20% will meet criteria for a substance use disorder. And on the right, you'll see what we actually do when it comes to diagnosis and prescription. So only about 8 or 9% of patients are actually getting these diagnoses and getting these prescriptions, even though statistically we should be seeing somewhere in the 18% range. Opioid use disorder prescription is even worse. Alcohol use disorder prescription, nearly negligible. And, you know, this is a topic that's really important to me. We should be experts in this. We should be leaders in this. This should be in our wheelhouse as psychiatrists, and we've got to do better. So how do we do that? Well, one thing that we can do is influence the structures of systems. The HRSA department actually decided, okay, what can we do to actually try to combat opioid use disorder? So they created an initiative that increased loan repayment for clinicians that were going to treat patients with substance use disorders or substance use disorders in rural communities. And they collected data from 2017 to 2021. And they looked at Medicaid beneficiaries, but then they also did a study talking to why people were doing what they were doing. So the first thing here is the Medicaid beneficiaries receiving buprenorphine increased. This was a good intervention. 18% before the intervention, 43% after. Those with high social vulnerability scores, so those who are living in communities that had a higher risk, were actually treated at an increased rate, which is fantastic. Again, 17% before, 36% after. And then rural communities were getting better treatment as well. Unfortunately, even with this improvement, there was actually still quite a significant problem. And that was when you asked respondents, so the 2,140 physicians who qualified for this program, whose primary goal was to actually help the opioid use disorder problem in the United States, almost half of them didn't actually prescribe buprenorphine. So why didn't they do that? Number one reason was concern over diversion, 43%, lack of mental health services to complement MOUD, lack of supervision, mentorship, or peer consultation, and then organizational factors. So despite this really great program, there were significant problems with education regarding how to take care of patients who are experiencing these issues. Similarly, the 2023, the buprenorphine waiver was actually eliminated. So now anyone with a DEA can prescribe buprenorphine, which is fantastic. This was thought to be a significant barrier for patients because physicians didn't want to do the 8-hour training. You had to sign up for the X waiver. After having done many of these trainings, I noticed in particular that people would do the training, but still not actually prescribe. And when this was put into law in Congress in last year, I sent this email out to our addiction interest track saying this is a wonderful intervention. I'm so glad this is happening. And really interestingly, one of the mentors that I have worked with, who's works at Evergreen and directs their program for methadone, actually asked the controversial question, well, is that actually going to change anything? And the answer to that is really not as much as we want. So this was a letter from the New England Journal where this group of really smart statisticians took a look at what the trends were in 2022 for A, buprenorphine prescribers, B, number of patients that buprenorphine was actually dispensed to, and then C, whom buprenorphine treatment was even initiated. So what you'll see there is that, yes, the buprenorphine prescribers increased, but the actual patients who got buprenorphine, not so much. Those who treatment was initiated, maybe a little bit of an increase, but the actual dispensing of the medication really did not track along. So looking at that, looking at the problems that we have, what are the actual projected needs based on HRSA estimates? So the demand for behavioral health overall actually has increased by 12% over the course of the last 3 years. Unfortunately, the supply has actually decreased by 3%. And by 2036, behavioral health clinicians will really need to be at 62% increase. Unfortunately, what we're looking at is an estimated decrease of 13%. And when you look at the breakdown of this, one of the most alarming ones is addiction counselors actually is the highest rate of need with the most rate of decrease. And there's a lot of reasons for that, which we can discuss at some point. So what is happening with training? How is education actually influencing this? I thought this study was really telling when it comes to looking at the hidden curriculum, if you will. So this was a physician in training study that asked medical students and PGY 1 through 4 residents in surgery, emergency medicine, and internal medicine, 200 respondents. And what they found was unfortunate. Satisfaction for caring for those who use drugs and alcohol diminished over the years of training. They had consistent beliefs that providing care to patients who use substances is repetitive and detracts from others. And all actually felt that they had adequate training to take care of patients with substance use disorders. So in psychiatry, we are really thoughtful about the idea that we should be helping patients with substance use disorders. We have an entire month of FTE, according to ACGME, required during general psychiatry residency in these areas. So we must be better at this, correct? Unfortunately, not so much. So this is a resident attitude in psychiatry and shows very similar results. Of the 159 surveyed, there were more stigmatizing attitudes towards individuals with substance use compared to schizophrenia or depression. And senior residents actually possessed more negative attitudes towards those with substance use than junior residents. So there's something happening in the hidden curriculum throughout training that is actually making people's perception of taking care of those who use drugs and alcohol worse. I've got a number of different theories on this, one of which is when you're taking care of people in medical school and residency, you largely do this on acute care services in hospital settings when people are really experiencing substance use consequences at their worst. They're in car crashes, they're withdrawing from alcohol or opioids. These are really difficult times for people with substance use disorders and really difficult times for the physicians taking care of them who may not have experience in what to do for these folks and have negative attitudes that are really wrapped up in the settings that we're educating the most influential learners. So we've got to change the attitudes from the inside on inpatient services, which I'll talk about momentarily. So how are we doing in terms of actually producing clinicians who are interested in doing the work of substance use? So on the right here, you can see actually psychiatry is booming. This is a field that is expanding. Medical students really are going into psychiatry at higher rates every year. This is fantastic. Actually, 2023 data is in the 2000s. So we're headed in the right direction there. But unfortunately, if you look at the numbers for those who are doing one-year fellowships in psychiatry, addiction, forensic, geriatric, consult liaison, all of them are remaining fairly static, if not actually decreasing, compared to the percentages of increase in psychiatry. And I put this slide I put this line for addiction medicine in here, which is a one-year fellowship in general internal medicine dedicated to taking care of those who have substance use. And what you'll see there is when they started tracking data in 2018 and 19, they have increased exponentially. Looking at fellowship matching data nationwide last year, if you look at addiction psychiatry, unfortunately, that is this third bar on the right here, only about half of our positions were filled last year. Of the 123, 62 were actually filled. Comparatively, child and adolescent, over 300 of their 375-ish positions were filled. CL psychiatry, almost 100 out of the 130 some, and addiction medicine, 100 in 20 something compared to the nearly 250. So addiction psychiatry actually didn't do as well. The reason geriatrics is not on here and forensics is not on here is that these are not matching programs, so they have rolling admissions processes, so we don't have specific data on that. So in summary, we've got substance use and overdose deaths that are an all-time high, a workforce demand that is outpaced by those who are leaving the field, providers that are less likely to prescribe medications than other psychiatric and medical problems, negative attitudes about patients with SUD that worsen actually over time in medical education, and less psychiatry residents going into addiction fellowships. So what do we do about it? This is the most depressing part of this talk. I promise it gets better. And we don't want to do the Chicken Little thing, which is, no, the sky is not falling. Those of you who know me know that my favorite band is Pearl Jam. There were 2 live shows this week, one which ended last night at like midnight. So I'm a little hoarse, I have to admit. But I love this lyric out of the song 7 O'Clock, which I actually think is a fantastic metaphor for this problem. And if you learn nothing from this talk today, you will potentially be able to save your life in a riptide. And that is if you spend time in the ocean surfing or playing around, riptides or undertows pull you straight out to sea. And if you swim against the current, trying to get back to the beach, you tire out, and that's when people drown. So I think we're doing that somewhat in medicine, trying to fight against the current, and instead we need to swim sideways from this undertow and do not be deterred. So we got to do things differently. Where do we intervene? And the answer to that is we intervene always in all ways. We've got to change the landscape of education through peer education, trainee education, interdisciplinary education, and mentorship. How do we actually do this? So Mass General had an initiative that changed the landscape of what they were doing in the hospital. They had 3 arms to this. They added an addiction consultation service. They added bridge clinics for those who had substance use disorders who were admitted to the hospital and needed follow-up care. And they embedded addiction champion teams in primary care settings who were facile with taking care of substance use. So they did this over the course of a few years, and they divided those who had interaction with the initiative, meaning, did you consult the addiction service? Did you send a patient to bridge care? Did you interact with an addiction champion team? Those who had interaction with the initiative had an attitude that was much better. 44% found caring for those with SUD satisfying compared to 9% without. Those who did not view treatments as replacement addiction, which is actually a good thing. 91% in the initiative, 72 in the no initiative category. Attitudes, percentage who feel prepared to take care of those by screening, diagnosing, brief intervention, referral to treatment, medication discussions, overdose education, harm reduction measures, all outperformed in the interaction with the initiative. And actual prescribing practices were also improved. Again, this is somewhat antiquated because it's 2017. I certainly hope there are more than 27% of prescribers giving naloxone out at this point. Everyone in the hospital who comes in with any SUD should be given a naloxone rescue kit. And then those who frequently or sometimes prescribe pharmacotherapy, again, these are internal medicine folks, but the numbers speak for themselves, significant increase. What about learners? So addiction consultation services. And if you haven't had any interface with addiction consultation services, the idea is that we are a service that is there for inpatient surgical, medical, psychiatric, neurology services for us to actually come by the bedside as a cardiology service would, as a neurology service would, as a nephrology service would, and give expert advice on initiation of medication, withdrawal management, starting buprenorphine or methadone in the hospital, and referral and connection to care. So this was a study out of Canada looking at a very brief intervention. So 2 to 4 weeks of a rotation on medical learners. These are medical students and residents. And what you found was even with this short period of time, the attitudes about taking care of those who have substance use disorders, they felt much more competent in doing so. Now, there's a paucity of data in actually how well people do. These are both attitude studies, and we need more data on actual competencies, how well they actually do. But this is a start. So what do we have here at the University of Washington? Thankfully, what I will say is that this is a wonderful place. We have an amazing addiction division. We have a lot of addiction psychiatrists and addiction medicine folks. And each of our hospitals does have an addiction consultation service. And specifically, these should be addiction teaching services. So they're staffed by addiction psychiatry and addiction medicine. Each of the hospitals is a little bit different, but the support staff also includes nursing and social work, which is incredibly important for the follow-up and connection to care. The learners on these services are addiction psychiatry fellows, addiction medicine fellows, general psychiatry residents, internal medicine and family medicine residents, and medical students. The services that we do, as I said, motivational interviewing, medications, quality improvement. Before our addiction consultation service was started at the VA, we did not allow phenobarbital in our hospitals to be dispensed on floors. We had a number of sentinel events where people would experience delirium tremens because we couldn't get them phenobarbital quickly enough. Our addiction consultation service, in partnership with the pharmacists and internal medicine folks, have changed that. So we now have phenobarbital on medical floors. So there is an influence from addiction consultation services that is far-reaching. We, by embedding ourselves into the hospital, we can help change the way that people think about our patients at the start. What we can do is normalize addiction treatment as an area of medical expertise. We are not taking care of patients in the annexed building behind where no one knows where it's occurring. The liaison potential here is to combat stigma, validate concerns of primary teams about what to do for these patients, demonstrate positive interactions with those who are really experiencing and suffering substance at their worst, and redefining where patient treatment can occur and who can provide the patient care. We should be doing this. It does not have to be some shishi clinic in Malibu where the substance use treatment occurs. And if you don't think stigma exists, I'll show you two slides. The first, I Google searched the term best treatment for substance use, and these were the top 5 images. So this occurs apparently in a beautiful place in the side of a mountain in Phoenix or in Malibu or on the beach. Really quite stigmatizing in terms of all of these folks looking wonderful and well and quite frankly, white. This is what you get when you Google search the term methadone. And I just will reiterate, methadone is one of the most successful treatments, one of the best treatments that we have in all of psychiatry. Methadone reduces overdose by 60% at 12 months. This is an amazing intervention and a really strong medication, but it is associated with this guy on the top right who looks terribly worried, an incarcerated person on the left, for some reason, someone who's or a needle and pills. That is not how we give methadone. It's in a liquid. We don't inject it. We don't give pills. And then a mother whose daughter looks despondent. This is the image that we are fighting against. So how can we actually improve outpatient substance use experiences? So patients in acute care settings, as I said, are more likely to be experiencing severe and active addiction. They're more ambivalent about care. They're in active withdrawal. It's very difficult sometimes to interact with them. They're irritable and stressed and at times despondent. In outpatient care, we have a significant limitation in how many rotations we have here. But you see these patients who are motivated for treatment. The learners get a chance to actually see people who are in recovery. Those are positive communities and they're very powerful. There are people who are amazing advocates, nurses, mental health staff, psychologists, physicians, MSA staff. And when you experience that culture, it really can change your attitude about what it's like to care for people who use drugs. Where do we currently have these? So Harborview Mental Health, UW, VA, we all have programs, but there are ways that we can expand. And what I will tell you about each of these places, when you ask learners, what makes Madison Clinic so much different than other clinics? They will tell you it's the clinicians there. When people rotate with Mark Duncan at the Northgate Clinic, they can see patients who are stable on buprenorphine and have a completely different view of substance use. They have a mentor there who can help guide them. And this is something that we need to really expand on. All of our outpatient clinics really should have the ability to take care of patients with substance use disorders. We cannot just silo these patients into high-ordered substance use treatment clinics and think that that's enough. It's wonderful when we have these rotations, but we need more. We have got to have continuity clinics, and we've got to have our providers, our psychiatrists who are educating these learners be facile with treatment of substance use themselves. So how also do we improve inpatient rotations? So here at the VA, one of the things, so I was medical director up until about 2 months ago. Thank you so much, Alvaro La Rosa, for taking that position. I loved working as medical director, but I am glad to be working on the addiction consult service now. But we changed really how inpatient psychiatry helped patients with substance use as a model for VA. So within inpatient psychiatry teaching services, we should be diagnosing SUD. We should be doing MI around SUD. We should be managing withdrawal. We should be taking care of patients and starting medications for substance use and referring to treatment as experts in this area. And we should use our addiction consult services to educate those who don't yet know all of these resources or how to actually prescribe and do this work. This is one thing that I think is so important, is that we do not have to remain static as attendings about what we are able to learn and do. Before I started on inpatient psychiatry, I really did not feel comfortable with geriatric issues. Managing dementia and agitation was not something that I really felt prepared to do. I had to learn it. And this is stuff that we can learn and we can do. How do we actually then also improve addiction fellowship recruitment? This is a problem. We have a number of positions for addictions and we're not filling them. So my colleague, Alexis Ritvo at the University of Colorado, had a great idea to actually survey general psychiatry residents. So far, and this is data ahead of press, it's not complete yet, there have been 122 respondents. Are you currently interested in an ACGME psychiatric fellowship? 28% said absolutely no. Why not? 70% said financial pressures. 56% thought that it did not actually increase earning potential, and 43% didn't believe that training was necessary. When they have an option to fast track, so if we added an idea of changing one-year fellowships to the potential of fast track, how many residents would consider doing a fellowship? 97% compared to 3. And how likely would you be? 63%. And which specialty would you choose? Addiction at 72%, CL almost 60%. I am absolutely open to discussion about this topic, but I will say ADPERT right now is not supporting this. There are a lot of competing interests, and I understand that, but this is a crisis that we're dealing with, and it is my strong belief that we need to change this. What else can we do? We created a model for interdisciplinary education at the VA. And this is a really cool thing that I think that we can do and model beyond addiction fellowship. So many of you know that the VA here is one of the 2 centers of excellence in education surrounding addiction. And so there are fellows in social work, in psychology, chaplains. And what we've done is integrated our educational seminar to include addiction psychiatry fellows, medicine fellows. We actually added the Swedish addiction medicine fellows who primarily take care of women and those who are pregnant. Apologize for that language. Those who are pregnant or in and around the time of pregnancy, who are experiencing substance use. Residents on rotation, psychiatrists, medicine residents, medical students. And what we do is we have a summer seminar, which is basically an overview of general substances of abuse. And then September through January, interdisciplinary topics that are presented by various experts in backgrounds in psychology, pharmacy, social work, physicians, chaplains. And then later in the year, January through June, the fellows actually then present topics to one another. So their area of expertise that they've learned throughout the year, they educate one another. This is also one extra thing we do is a multi-day motivational enhancement workshop, and we do weekly MI practice. So this model is really an interdisciplinary model that really allows, at least in my experience, subspecialists in other areas to understand what a colleague is doing from social work or from psychology or from pharmacy. One other service that has been going on since 2016, you probably recognize some colleagues in this, the UW PACC. So this is a weekly teleconference that is free to community providers. Psychiatrists, psychologists, and addiction experts will staff this meeting. Our addiction fellows go to this meeting and present as well. Educational presentations occur and case presentations occur each week so that providers can actually get feedback. And what this also does is it creates a learning community. It changes the way that people are able to interact with one another in order to care for these patients who can be incredibly complicated. So this is a project that we've just started. I appreciate collaboration with Ryan and Molly, Athena, those from the PCL team, Jürgen. And what we're doing is expanding the scope of our psychiatry consultation line. So this is a 24-hour a day, 7-day a week. Many of you on this call are PCL providers yourself, and anyone from Washington State can call and ask mental health questions for adults. And what we've done is we've actually expanded that to also include substance use disorders. So what did we do and how did we do that? The idea overall is to improve specifically the treatment of OUD and reduce overdose deaths. So Dr. Kimmel, myself, and Dr. Unitzer came up with this model. And what we're doing is all of the current PCL providers were actually given a very specific training that I developed to address the question of OUD in the fentanyl era. Very specific about this topic, 2.5 hours, really focused on helping those in the community who are trying to initiate buprenorphine. These asynchronous trainings are now available to providers on the website, which I'll show you in a second. The other thing we did was we added an addiction psychiatrist coverage for PCL providers as a backup. So now 24 hours a day, 7 days a week, 365 days a year, if a PCL provider has a question about a very complex substance use case that the education that we provided in these trainings does not particularly cover, they can call one of us to get expert opinion on this in real time. I do monthly chart reviews of the recommendations that we are giving to ensure fidelity. We also produce ongoing educational materials with case conference discussions. So really complicated patients who may not fit into the algorithms that we've developed in the educational materials. We discuss them and talk about teaching points and create one-page handouts or cheat sheets in order to improve understanding of diagnosis and treatment. The other thing is, in partnership with the Bridge program and ADAI, we have developed clinical protocols and educational materials that are available at Scala Northwest. This is the new website that will be up and running as of tomorrow completely. And you can see a tremendous amount of folks have been involved in the development of these protocols. This involves many folks who are experts in our department, as well as community providers, everywhere from addiction psychiatry to emergency medicine and methadone clinics. So lastly, and I can't stress this enough, that I think mentorship is incredibly important. So Andy Saxon and Rick Reese started this track 25 years ago within our department that pairs learners, medical students, residents who are interested in taking care of folks who use substances with experts in our department and community providers. We have dinner a couple times a year, 4 or so times a year, and have a presentation, but it creates this community. And for me, it made a giant difference in my career. I'm just listing a few of the folks here who have had such a positive impact on me and educating me about how we actually go about this work. And we are very lucky at the University of Washington that we have such a deep bench and such an amazing group of folks who do this work. So with that, I'm actually going to stop. I want to make sure that I have time to answer questions that those in the audience might have. And thank you again for having me.
Thank you, Jonathan. I think we've learned a lot about the scope of educational efforts in addiction, some of the challenges, and now ways that education and clinical care, such as with the PCL, are kind of blending together. And then one of the questions that came in is actually about the PCL. And there's a question about whether those who are calling in, do the addiction specialists talk directly to the callers, or is that advice given to the psychiatrists who are covering the PCL?
Yeah, so the primary psychiatrist who's covering PCL is fielding the question to start. And the idea is that the ongoing training that we're doing both with the opioid use disorder lectures and ongoing educational materials provide enough information that the general psychiatrist will be able to actually impart information. And what I've seen so far is our psychiatrists are doing a wonderful job. Those with not a ton of specific experience treating patients with substance use disorders, aside from their general clinics and general practice, with some specific areas of education, are really providing excellent recommendations. And if they aren't able to actually answer the question, for instance, there was one question about a really complicated patient in an emergency room setting who is using multiple substances, amphetamines, opioids, benzodiazepines, and alcohol, which was a very appropriate reason to call me because these are really challenging folks to know what to do with. The PCL provider gave me a phone call and we discussed it. But the idea is actually that we're sort of the backup line, if you will. And hopefully that it also, from a downstream perspective, can help educate our own folks in the department and providers in the community range. So primary care can call, emergency rooms can call, et cetera. There's also a fantastic line from the emergency room at Harborview that serves King County. Emergency medicine docs can call this and talk to colleagues. So, for instance, Kaylin, sorry about that. Kaylin is one of our providers at Harborview, and a number of the Harborview folks are champions in this area answering these questions.
I encourage any participants to write in questions or comments. We do have time. And I guess while others are writing questions, I might pose one. Jonathan, I appreciated your point about continuing to learn in the practice setting that you're in, like with older adults, as you mentioned on your hospital service. And I guess I wonder for general psychiatrists, general clinicians in hospital settings, if they haven't learned a lot about addiction yet, would you sort of propose learning some fundamentals that might apply across substances, hyper-focusing in on one substance in particular? What might be the next step?
Yeah, that's a great question. I really appreciate that. So, there's a couple ways to skin this cat. One is, do CME. I actually think that that's a generic answer that's not terribly useful for a lot of people. Instead, one of the amazing things that we have about our department, built on Dr. Saxon and Dr. Reese's dedication to producing addiction psychiatrists. So I counted back, actually, this department has produced almost 60 addiction psychiatrists since the inception of the fellowship by Dr. Saxon in the late 90s. And this is one of the oldest programs in the country. But what happens is then you have colleagues who are embedded into your general services that you can ask. So Mark Duncan is at Northgate. Nathan Sackett is at Roosevelt. Nadia Bespalova is at UW and Harborview. Nora Asali and Matt Ilshi are at Harborview. I'm here at the VA. David Veith is here at the VA. Tim Bondurant's at the VA. So identify those colleagues within your department and ask them. We're all super interested in improving the care and educating. And the truth of the matter is, you know, people shouldn't feel shame in not understanding what to do with these patients. Just as I said with geriatrics, I didn't know how to take care of patients with agitated dementia. Despite having a great geri rotation, it wasn't enough. And I, called on Dr. Pasquale and Dr. Murray, Dr. Borzovskaya to learn those things. And we want the same thing to occur with our addiction experts. If you're not an addiction psychiatrist, you can learn this. And you shouldn't feel shame in not knowing the answer. It's just about ongoing education.
Well, I encourage others to write in with comments or questions. I've got a lot more, but I do want to hear what others are curious about. I don't see one for now, so I wonder you've trained a lot of people at a lot of different levels, from students through colleagues, and I wonder in what way do you see their questions evolving over time?
That's a great question, and I'm heartened actually. So there is actually an addiction interest group amongst second-year medical students. When I was a medical student, that did not exist, and now each year there's roughly 40 to 50 medical students who join this very specific interest group. I think that the younger learners are very interested in taking care of these folks and learning about these topics. And I think those who have been in practice a long time, who are seeing, this health crisis, want to know more as well. So I think people are really open and interested. I think that previously the sort of fear of, I don't know what to do with these people, I don't know where to send them, those are understandable fears. And I think that our systems have improved to actually deliver this care within each of our settings. But I'd also say, if you are a clinic director, if you are the director of an inpatient service within our systems, think about ways that you can actually improve the care of patients who are using substances. If you don't know, ask the addiction people who are in that, who are specialized in this area, who can give ideas. Because I really do think that it has to change from a cultural perspective everywhere. And when you change the culture of caring for people in all of the settings that we see people in, then we don't have to just do addiction clinics that are very specific about buprenorphine education. You can do buprenorphine treatment at a primary care clinic or at a general outpatient mental health clinic.
Here's perhaps a very specific question for learners and students trying to gain more experience in substance use disorder assessment, treatment. What if places are kind of full? Where else can people go to learn? And I don't know if that relates to medical students specifically, or what exactly that might refer to, but that's the nature of the question. Where else can people look to learn in a clinical setting?
So, I think we often, as physicians think about the medical treatment aspect. And I think that, you know, when you actually look at substance use treatment, when it's done very well, it really requires a lot of coordination. And you can see this in a rotation, for instance, through DESC, where it may not, it may not be just about substance use care. It may be about treating those with severe mental illness and coordinating care. A lot of these folks present very similarly to those who are in crisis. So general inpatient units, those models can be applied to substance use, and you can learn about that in those ways. We also, I think, have the ability to think about expansion of how and where we do the training. Those are more complicated because they involve budgets and things like that. But I think that our department is really interested in it, and I've, you know, felt nothing but supportive on this topic, and so I think the future is exciting here.
Thank you. And we have a couple more minutes. I encourage anyone to write in a question or comment. And I maybe I'll ask this as someone else is thinking of a question. I see patients in the same clinic as Nadia and Nathan that you mentioned. We have a system in place for posing questions to each other, and it's really been a source of help in major ways. What do you see? I mean, in a typical outpatient psychiatry mental health clinic, what's maybe a high yield type of QI project related to substance use disorder treatment assessments? Yeah, what have you seen go well?
Yeah. So what I would say actually is nothing involving the actual medications and everything involving the systems. So do you have an MSA and a system that is able to actually schedule somebody for a visit when they want it? So if a patient who's using fentanyl every single day, 17 times a day, says, "Can I get help?" and we tell them, "Sure," in 6 months, that is not useful. So if we could have system improvements to get the patients connected to the care, which is a lot of work, right? It's heavy lifting on the part of MSAs, of nurses, of insurance and billing. I mean, these are really complicated things to coordinate. But when you look at clinics who are doing this work really well, for instance, Madison Clinic, they've been working on those systems issues for years. And when you ask somebody like Joe Merrill, what is the most helpful thing, he'll say the MSA who follows up, who calls and says, "Hey, you have your appointment coming up." So very practical things.
Yeah, it's very interesting. We may have a tendency to get stuck on a medical decision, but that's not often the highest yield. Sounds like in this case.
The second is
Yeah.
buprenorphine.
Okay, well, there you go.
Buprenorphine.
Okay.
It saves lives. It is incredibly safe. Yeah, that would be the second thing. Buprenorphine everywhere.
Well, look, here we are. I don't see additional questions. We're just at 1 o'clock here. I appreciate the timing of this presentation here as we're concluding this academic year. It's one that I think people can think about, feel motivated by in their own clinical practice and their educational efforts over the next few months and at the start of the next academic year. And I appreciate it, and thank you for presenting today in Grand Rounds.
Absolutely. I really appreciate you having me. Thank you.
Yep. Okay. Thank you.
Thanks.